Pancreatic cancer. Welcome to today's podcast, where we discuss the main aspects of pancreatic cancer. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the management of pancreatic cancer. Pause the podcast after each question to attempt answer. Let's begin. Introduction question. What is the prevalence and mortality rate of pancreatic ductal adenocarcinoma in the United States? Answer. Pancreatic ductal adenocarcinoma is the third leading cause of cancer-related death in the United States and is becoming increasingly common. Question. What challenge exists in the early detection of pancreatic ductal adenocarcinoma? Answer. The absence of effective early detection methods results in late-stage diagnosis for over 80% of patients with pancreatic ductal adenocarcinoma. Question. How have advancements impacted the prognosis and treatment of pancreatic ductal adenocarcinoma? Answer. Although the 5-year overall survival rate remains low, progress in treatment sequencing and systemic therapies offers hope for better patient outcomes. Epidemiology question. Which molecular driver is nearly universal in pancreatic ductal adenocarcinoma, and what role do genomic rearrangements play? Answer. Mutations in the KRAS gene are found in almost all cases of pancreatic ductal adenocarcinoma, and catastrophic genomic rearrangements accelerate the malignant transformation process. Question. What is a common histologic feature of pancreatic ductal adenocarcinoma? Answer. Pancreatic ductal adenocarcinoma is characterized by a dense desmoplastic stroma. Question. What risk factors contribute to the development of pancreatic ductal adenocarcinoma? Answer. Familial gene mutations, chronic pancreatitis, pancreatic cysts, and diabetes mellitus are recognized contributors to the pathogenesis of pancreatic ductal adenocarcinoma. Hereditary risk factors. Question. What is recommended for all individuals diagnosed with pancreatic ductal adenocarcinoma regarding genetic testing? Answer. Genetic testing is recommended for every individual diagnosed with pancreatic ductal adenocarcinoma. Question. Which hereditary syndromes are associated with increased risk of pancreatic ductal adenocarcinoma? Answer. Hereditary syndromes such as BRCA1, BRCA2, PALB2, CDKN2A, and STK11 are associated with an increased risk of developing pancreatic ductal adenocarcinoma. Question. Is the genetic basis of inherited susceptibility to pancreatic ductal adenocarcinoma fully understood? Answer. The genetic basis of inherited susceptibility to pancreatic ductal adenocarcinoma remains largely unknown, despite the availability of genetic testing. Question. Who is considered high risk for pancreatic ductal adenocarcinoma? Answer. Individuals with a strong family history of pancreatic ductal adenocarcinoma or familial pancreatitis are categorized as high risk. Question. How does risk differ between hereditary pancreatic ductal adenocarcinoma syndromes and familial pancreatic cancer syndromes? Answer. Individuals with hereditary pancreatic ductal adenocarcinoma syndromes have a higher risk of developing the disease compared to those with familial pancreatic cancer syndromes. Question. What is the recommended surveillance approach for high-risk individuals? Answer. Imaging-based screening is considered cost-effective and appropriate for high-risk individuals, whereas population-wide screening is not recommended due to the low average lifetime risk in the general population. Question. How effective is high-risk surveillance in detecting pancreatic ductal adenocarcinoma or high-grade dysplasia? Answer. High-risk screening identified one patient with high-grade dysplasia or pancreatic ductal adenocarcinoma for every 135.6 individuals screened. Question. What impact does high-risk screening have on the resectability of pancreatic ductal adenocarcinoma? Answer. 60 to 80% of pancreatic ductal adenocarcinomas detected in the screened population were resectable. Question. What psychological benefits are associated with high-risk screening for pancreatic ductal adenocarcinoma? Answer. Individuals who undergo high-risk screening experience reduced psychological distress and lower levels of cancer-related worry. Acquired risk factors. Question. What lifestyle and metabolic factors are associated with increased risk of pancreatic ductal adenocarcinoma? Answer. Tobacco use, alcohol consumption, and obesity are associated with an increased risk of pancreatic ductal adenocarcinoma. Question. How does obesity influence the risk of pancreatic ductal adenocarcinoma? Answer. Obesity is correlated with pancreatic ductal adenocarcinoma and is associated with a 1.72-fold increased risk of developing cancer. Question: what is the relationship between diabetes and pancreatic ductal adenocarcinoma? Answer: individuals with diabetes, especially those with new-onset diabetes accompanied by weight loss, have a heightened risk of pancreatic ductal adenocarcinoma. Pathogenesis question: what types of cells are found in the pancreas, and what are their respective functions? Answer: the pancreas contains predominantly exocrine cells that secrete digestive enzymes, bicarbonate, and water, as well as endocrine cells, primarily located in the islets of Langerhans, which produce hormones such as glucagon, insulin, and somatostatin to regulate glucose homeostasis. Precursor lesions question: from which precursor lesions do most pancreatic ductal adenocarcinomas arise? Answer: most pancreatic ductal adenocarcinomas originate from pancreatic intraepithelial neoplasias, with a smaller proportion arising from intraductal papillary mucinous neoplasms. Question: how are pancreatic intraepithelial neoplasias categorized? Answer: pancreatic intraepithelial neoplasias are classified as low-grade or high-grade based on architectural and cytologic atypia. Question: what distinguishes intraductal papillary mucinous neoplasms from mucinous cystic neoplasms? Answer: intraductal papillary mucinous neoplasms are macrocystic lesions involving the pancreatic ductal system, while mucinous cystic neoplasms are clinically and pathologically distinct and do not involve the ductal system. Question: what are the histological features of pancreatic ductal adenocarcinoma? Answer: pancreatic ductal adenocarcinoma is characterized by malignant glands with irregular architecture embedded in a dense desmoplastic stroma. Question: where are metastatic sites most commonly found in pancreatic ductal adenocarcinoma? Answer: at diagnosis. Pancreatic ductal adenocarcinomas are often not confined to the pancreas, with the liver and peritoneum being the most frequent sites of metastasis. Question: what is the significance of SMAD4 mutation in pancreatic ductal adenocarcinoma? Answer: mutation of the SMAD4 gene is associated with an increased likelihood of distant metastasis and progression to systemic disease. Molecular alterations question: what is the most common gene mutation in pancreatic ductal adenocarcinoma, and what is its effect? Answer: the KRAS gene is mutated in over 90% of pancreatic ductal adenocarcinoma cases, resulting in impaired GT-PASA activity and activation of multiple signaling pathways. Question: which other gene mutations are frequently observed in pancreatic ductal adenocarcinoma, and what processes do they affect? Answer: mutations in TP53, CDKN2A, and SMAD4 are often found in pancreatic ductal adenocarcinoma, impacting DNA damage recognition, cell cycle regulation, and transforming growth factor beta signaling, respectively. Question: are KRAS mutations in pancreatic ductal adenocarcinoma potentially targetable by specific therapies? Answer: emerging evidence indicates that KRAS mutations may be susceptible to mutant-specific targeted therapies. Question: what genetic alterations are present in pancreatic ductal adenocarcinoma? Answer: genetic alterations in pancreatic ductal adenocarcinoma include mutations in ARID1A, BRAF, TGFBR2, SWI/SNF, and SMARCA4, as well as large chromosomal changes such as copy number alterations and chromothripsis. Question: what are the main transcriptomic subtypes of pancreatic ductal adenocarcinoma? Answer: pancreatic ductal adenocarcinoma comprises two principal transcriptomic subtypes, classical and basal-like, with the basal-like subtype linked to more aggressive behavior and poorer prognosis. Question: how do transcriptomic subtypes relate to treatment response in pancreatic ductal adenocarcinoma? Answer: the basal-like subtype is associated with poor response to 5-fluorouracil-based treatment regimens, and prediction of RNA subtype is being evaluated in clinical trials. Clinical management. Clinical presentation question: what are common presenting symptoms of pancreatic ductal adenocarcinoma? Answer: jaundice, upper abdominal or back pain, weight loss, nausea, vomiting, and new-onset diabetes are frequent presenting symptoms. Question: what physical examination finding may suggest metastatic disease in pancreatic ductal adenocarcinoma? Answer: palpable lymph nodes in the periumbilical region or left supraclavicular area may indicate metastatic disease. Question: Why is genetic counseling and testing recommended for all patients with pancreatic ductal adenocarcinoma? Answer. Genetic counseling and testing are recommended for all patients, regardless of age or disease stage, due to possible therapeutic implications. Diagnostic studies question. What is the preferred initial diagnostic imaging for pancreatic ductal adenocarcinoma, and why? Answer. Computed tomography scan is favored over endoscopic retrograde cholangiopancreatography for initial diagnosis to avoid obscuring tumor visualization and to evaluate for distant metastasis. Question. Why is endoscopic retrograde cholangiopancreatography not recommended as a first-line diagnostic tool for pancreatic ductal adenocarcinoma? Answer. Endoscopic retrograde cholangiopancreatography is not recommended due to its risk of causing pancreatitis and potentially obscuring tumor assessment. Question. What protocol should be followed for computed tomography scans in pancreatic ductal adenocarcinoma diagnosis? Answer. A high-quality computed tomography scan with chest and pancreatic protocol using 1 mm slice thickness and incorporating late arterial and venous phases is recommended for optimal tumor visualization and staging. Question. What information does cross-sectional imaging provide in the assessment of periampullary tumors? Answer. Cross-sectional imaging offers valuable details regarding the origin of the periampullary tumor, including the anatomical relationship between the tumor and surrounding vessels. Question. What are typical imaging characteristics of pancreatic ductal adenocarcinoma? Answer. Pancreatic ductal adenocarcinoma often presents as a mass in the head of the pancreas, with a double duct sign and distal pancreatic atrophy. Question. How can other periampullary tumors differ from pancreatic ductal adenocarcinoma in their effects? Answer. Ampullary adenocarcinomas, duodenal adenocarcinomas, or distal cholangiocarcinomas may cause biliary obstruction without simultaneous pancreatic ductal obstruction or atrophy. Clinical staging question. What are the two main clinical stages of pancreatic ductal adenocarcinoma? Answer. Pancreatic ductal adenocarcinoma is classified into potentially operable, resectable and borderline resectable, and likely inoperable, locally advanced and metastatic stages. Question. How is resectable pancreatic ductal adenocarcinoma defined? Answer. Resectable pancreatic ductal adenocarcinoma is defined by the absence of tumor extension to the superior mesenteric artery, celiac axis, or hepatic artery, with limited involvement of the superior mesenteric vein or portal vein confluence. Question. What characterizes borderline resectable pancreatic ductal adenocarcinoma? Answer. Borderline resectable disease is characterized by tumor abutment of the superior mesenteric artery or celiac axis up to 180 degrees, which may be amenable to neoadjuvant therapy for achieving complete resection. Question. What are considered resectable tumors in pancreatic ductal adenocarcinoma? Answer. Tumors suitable for surgical removal often involve a segment of the hepatic artery or an occluded superior mesenteric vein or portal vein. Question. What defines locally advanced pancreatic ductal adenocarcinoma? Answer. Locally advanced tumors are marked by arterial encasement or occlusion of the superior mesenteric vein or portal vein without possibilities for reconstruction. Question. How is metastatic pancreatic ductal adenocarcinoma identified? Answer. Metastatic disease is defined by the presence of tumor spread beyond the pancreas. Endoscopic procedures question. What is the preferred method for obtaining tissue diagnosis in pancreatic ductal adenocarcinoma? Answer. Endoscopic ultrasound with fine needle aspiration is preferred over percutaneous computed tomography guided biopsy for tissue diagnosis. Question. What are the advantages of endoscopic ultrasound with fine needle aspiration biopsy? Answer. This technique provides higher diagnostic success rates and allows for simultaneous tissue diagnosis and therapeutic intervention. Question. Which type of stent is preferred for biliary drainage in pancreatic ductal adenocarcinoma, and why? Answer. Uncovered metal stents are preferred due to their higher patency rates and lower complication rates. Covered stents are used in specific scenarios, such as in patients without a gallbladder or when tissue diagnosis is pending. Laboratory studies question. What standard laboratory tests are recommended for patients with pancreatic ductal adenocarcinoma? Answer. Recommended tests include complete blood count, comprehensive metabolic panel, albumin, hemoglobin A1c, and tumor markers such as carbohydrate antigen 19-9, carbohydrate antigen 125, and carcinoembryonic antigen. Question: what is the significance of carbohydrate antigen 19-9 as a tumor marker in pancreatic ductal adenocarcinoma? Answer: carbohydrate antigen 19-9 is elevated in approximately 75% of patients at diagnosis, with levels correlating to treatment response, and should only be evaluated when total bilirubin is less than 2 mg per deciliter. Question: how is carcinoembryonic antigen used as a tumor marker in pancreatic ductal adenocarcinoma? Answer: carcinoembryonic antigen is elevated in 25% of carbohydrate antigen 19-9 non-producers. Trends with treatment response and prognosis, and levels are higher in smokers. Treatment question: what is the recommended treatment approach for pancreatic ductal adenocarcinoma? Answer: treatment is stage-specific and requires a multidisciplinary approach for non-metastatic pancreatic ductal adenocarcinoma. Question: which specialists are typically involved in the multidisciplinary team for pancreatic ductal adenocarcinoma care? Answer: the team includes surgeons, medical oncologists, radiation oncologists, gastroenterologists, imaging specialists, pathologists, genetic counselors, dietitians, physical therapists, and palliative care specialists. Question: why is care coordination crucial in the management of pancreatic ductal adenocarcinoma? Answer: effective care coordination ensures timely and appropriate treatment, optimizes patient outcomes, and minimizes delays and side effects. Multimodality approach to operable pancreatic adenocarcinoma. Question: what is the risk of recurrence for patients with operable pancreatic ductal adenocarcinoma? Answer: patients with operable pancreatic ductal adenocarcinoma have a high risk of both local and systemic recurrence, with more than 75% experiencing recurrence within 1 year of surgery. Question: what is the recommendation regarding adjuvant therapy for patients undergoing surgery for pancreatic ductal adenocarcinoma? Answer: adjuvant therapy is recommended for all patients who undergo surgery, regardless of the pathological stage, due to the high recurrence rates. Question: what challenges exist in delivering adjuvant therapy after pancreatectomy? Answer: delivery of adjuvant therapy is unpredictable, with about 50% of patients not receiving it due to complications, recovery issues, or refusal. Question: what limitation is associated with assessing treatment response in the adjuvant setting for pancreatic ductal adenocarcinoma? Answer: assessing treatment response is limited or impossible in the adjuvant setting because the primary tumor has already been removed. Question: how effective is adjuvant chemotherapy in pancreatic ductal adenocarcinoma? Answer: chemotherapy response rates in the adjuvant setting range from 30 to 50%, meaning that at least half of patients do not benefit. Question: what percentage of patients in a surgery-first approach receive adjuvant therapy? Answer: only 51% of patients in the surgery-first group received adjuvant therapy, highlighting the difficulties in implementing this strategy. Question: what are the advantages of neoadjuvant therapy in pancreatic ductal adenocarcinoma? Answer: neoadjuvant therapy allows for early systemic treatment, assessment of tumor biology, evaluation of treatment response, and improved patient selection for surgery. Question: how do changes in carbohydrate antigen 19-9 levels relate to treatment response and survival? Answer: changes in carbohydrate antigen 19-9 levels correlate with treatment response and overall survival in patients with elevated levels at diagnosis. Question: what proportion of patients who begin neoadjuvant therapy can complete it and undergo surgical resection? Answer: approximately 70% of patients who start neoadjuvant therapy are able to complete it and proceed to surgical resection. Trials comparing neoadjuvant therapy versus surgery. First question: what are the survival benefits of neoadjuvant therapy compared to surgery-first approaches in pancreatic ductal adenocarcinoma? Answer: neoadjuvant therapy improves overall survival for both resectable and borderline resectable pancreatic ductal adenocarcinoma patients compared to surgery-first strategies. Question: what is the median overall survival for patients completing neoadjuvant therapy and surgery? Answer: median overall survival exceeds 40 months at most centers for patients who complete neoadjuvant therapy followed by surgery. Question: what did the NORPACT-1 trial reveal about survival differences between upfront surgery and neoadjuvant chemotherapy in resectable pancreatic ductal adenocarcinoma? Answer: The NORPACT-1 trial found no significant difference in median overall survival between upfront surgical resection and neoadjuvant chemotherapy for patients with resectable pancreatic ductal adenocarcinoma in the head of the pancreas. Trials comparing neoadjuvant therapeutic approaches. Question: what is the current status of neoadjuvant therapy adoption for localized pancreatic ductal adenocarcinoma? Answer: neoadjuvant therapy is widely adopted for localized pancreatic ductal adenocarcinoma, is recommended for borderline resectable disease, and is increasingly advocated for resectable disease. Question: what are the future research priorities for optimizing neoadjuvant therapy in pancreatic ductal adenocarcinoma? Answer: future research will focus on determining the optimal chemotherapy regimen, treatment duration, and the role of radiation therapy. Question: what is the current debate regarding the value of neoadjuvant radiation therapy in pancreatic ductal adenocarcinoma? Answer: the value of neoadjuvant radiation therapy is being questioned after the Alliance A012501 trial showed no benefit and a higher rate of distant disease progression in the radiation group. Question: how important is the management of treatment-associated toxicity in operable pancreatic ductal adenocarcinoma? Answer: managing treatment-related toxicity is essential for patients with operable pancreatic ductal adenocarcinoma. Question: what is the concern regarding local recurrence in pancreatic ductal adenocarcinoma? Answer: local-only recurrence is a significant issue, with 30 to 40% of patients experiencing it as the first site of recurrence. Question: what neoadjuvant therapy approach is employed by the Medical College of Wisconsin for operable pancreatic ductal adenocarcinoma? Answer: the Medical College of Wisconsin uses a total neoadjuvant therapy approach, which includes chemotherapy, radiation, and adaptive trial design. Surgical management. Preoperative preparation. Question: what imaging is essential for preoperative staging in pancreatic ductal adenocarcinoma? Answer: a pancreatic protocol computed tomography scan is essential for staging and should be performed within 1 month of the planned surgery. Question: why is careful evaluation of tumor-vessel relationships important before surgery? Answer: careful evaluation of the tumor's relationship to the superior mesenteric artery, superior mesenteric vein, portal vein, celiac axis, and hepatic artery is crucial, including assessment for aberrant arterial anatomy and median arcuate ligament compression. Question: what venous anatomy details should be assessed preoperatively? Answer: the insertion of the inferior mesenteric vein and the location of the first jejunal branch should be noted, as this information helps anticipate the need for autologous conduits. Pancreaticoduodenectomy. Question: what does the pancreaticoduodenectomy procedure involve? Answer: pancreaticoduodenectomy entails removal of the pancreatic head, duodenum, gallbladder, and bile duct, with possible inclusion of the gastric antrum. Question: what is the purpose of diagnostic laparoscopy before pancreaticoduodenectomy? Answer: diagnostic laparoscopy is recommended to detect small volume metastatic disease not visible on preoperative imaging. Question: what incision and technique are typically used in pancreaticoduodenectomy? Answer: an upper midline incision is standard, with the round ligament preserved as a flap to cover the gastroduodenal artery stump after the procedure. Resection of the head of pancreas. Question: how is the infrapancreatic superior mesenteric vein identified during the procedure? Answer: the infrapancreatic superior mesenteric vein is identified by elevating the greater omentum, mobilizing the hepatic flexure, and incising the visceral peritoneum along the pancreas's inferior border. Question: how is the middle colic vein managed during pancreaticoduodenectomy? Answer: the entry of the middle colic vein into the superior mesenteric vein is identified, and its management depends on its relationship with the gastroepiploic vein and the extent of tumor involvement. Question: what tumor-related factors may necessitate modifications to the pancreaticoduodenectomy procedure? Answer: extensive scarring, large tumors, or tumors involving the uncinate process or duodenum may require dividing the middle colic vein, resecting mesentery, or performing a Caudal-Brosch maneuver. Question: what is the objective of the Kocher maneuver in pancreaticoduodenectomy? Answer: the Kocher maneuver aims to mobilize the duodenum and head of pancreas. Question: how is the Kocher maneuver performed? Answer: the procedure begins at the third portion of the duodenum, with identification of the inferior vena cava, and mobilization of the duodenum and pancreatic head medially to the level of the left renal vein and aorta. Question: How is the visceral peritoneum divided during the procedure? Answer. The visceral peritoneum is divided from the retroperitoneum to the posterior aspect of the mesenteric vessels, with lymphatics ligated when possible. Question. What is involved in portal dissection during pancreaticoduodenectomy? Answer. Portal dissection involves defining the superior border of the pancreatic head by identifying the common hepatic artery and removing the hepatic artery lymph node. Question. What steps are taken for vascular identification during pancreaticoduodenectomy? Answer. The right gastric artery is ligated, and the origin of the gastroduodenal artery is dissected before ligation. Question. How is bile duct management handled during pancreaticoduodenectomy? Answer. The common hepatic duct is transected at the level of the cystic duct. Biliary fluid cultures are sent, and any endobiliary stents are removed. Question. How is the anterior surface of the portal vein accessed during surgery? Answer. The common hepatic duct is used to access the anterior surface of the portal vein for dissection and mobilization of the gastroduodenal artery and proper hepatic artery. Question. What is a potential complication of overly aggressive dissection at the origin of the gastroduodenal artery? Answer. Excessive dissection at the origin of the gastroduodenal artery can result in intimal dissection of the hepatic artery. Question. What important anatomical feature is relevant during pancreaticoduodenectomy? Answer. The superior pancreaticoduodenal vein, also known as the vein of Belcher, is a tributary of the portal vein and drains the upper aspect of the pancreatic head, located at the superolateral aspect of the portal vein. Question. What is involved in duodenal and gastric transection during pancreaticoduodenectomy? Answer. The duodenum or stomach is transected, with pylorus preservation considered for small periampullary neoplasms but not for bulky tumors. The duodenum is usually divided about 2 cm distal to the pylorus to ensure adequate blood supply, and the stomach is divided at specific anatomical landmarks to complete a standard antrectomy. Question. How is jejunum division and mobilization performed in pancreaticoduodenectomy? Answer. The jejunum is divided approximately 10 cm distal to the ligament of Treitz, which is carefully mobilized to avoid injury to the inferior mesenteric vein. Question. How is the mesentery managed during pancreaticoduodenectomy? Answer. The mesentery is divided to the level of the fourth and third portions of the duodenum, and the devascularized segment is reflected to the right side of the abdomen. Question. What is the final step in resecting the pancreatic head during pancreaticoduodenectomy? Answer. The final step involves removing the pancreatic head from the superior mesenteric vein, portal vein, and superior mesenteric artery. Question. How is vascular control achieved during pancreaticoduodenectomy? Answer. Vessel loops are placed around the distal superior mesenteric vein, portal vein, and splenic vein for vascular control and medial retraction. Question. Why is full mobilization of the superior mesenteric vein-portal vein confluence important? Answer. Full mobilization is necessary to avoid injury to the superior mesenteric artery and facilitate direct ligation of the inferior pancreaticoduodenal arteries. Vascular resection question. When is vascular resection necessary during pancreaticoduodenectomy? Answer. Resection of the superior mesenteric vein and/or portal vein may be required if tumor extension prevents safe dissection from the pancreatic head and uncinate process. Question. How does preoperative planning assist with vascular resection? Answer. Preoperative imaging helps predict the need for vascular resection and allows for appropriate intraoperative planning. Question. What considerations are important during venous resection and reconstruction? Answer. When the superior mesenteric vein-portal vein confluence is resected, preserving the splenic vein is preferred to prevent sinistral hypertension. A tension-free anastomosis is ideal, but interposition grafting may be necessary. Question. What is the role of arterial resection in pancreatic ductal adenocarcinoma surgery? Answer. Arterial resection is controversial and should be reserved for highly selected patients who have undergone extensive neoadjuvant therapy. Question. What surgical considerations are necessary for vascular resection? Answer. High surgical morbidity and mortality require careful patient selection and performance at experienced centers. Question. Why are autologous grafts preferred for vascular reconstruction? Answer. Autologous grafts are favored over synthetic grafts due to lower infection risk and better long-term patency. Reconstruction question. How is pancreaticoduodenostomy performed during reconstruction? Answer. The pancreatic remnant is mobilized, The jejunal limb is passed through the transverse mesocolon, and either a two-layer or single-layer duct-to mucosa anastomosis is performed depending on the consistency of the pancreatic gland. Question: how is hepaticoduodenostomy constructed? Answer: a single-layer anastomosis is created about 10 cm distal to the pancreaticoduodenostomy using interrupted sutures, with proper alignment to avoid tension. Question: what is the technique for gastrojejunostomy reconstruction? Answer: an anticolic, end-to-side gastrojejunostomy is constructed at least 50 cm from the hepaticojejunostomy to minimize bile reflux cholangitis. Minimally invasive approaches. Question: what are the benefits of minimally invasive pancreaticoduodenectomy? Answer: minimally invasive pancreaticoduodenectomy offers decreased pain, fewer wound complications, and shorter hospital stays. Question: what is the learning curve for minimally invasive pancreaticoduodenectomy? Answer: proficiency in minimally invasive pancreaticoduodenectomy requires approximately 80 cases, although formal training can reduce this number. Question: which patients are suitable for minimally invasive pancreaticoduodenectomy? Answer: minimally invasive pancreaticoduodenectomy should be performed in carefully selected patients with favorable anatomy at experienced institutions. Post-operative care. Question: what standardized protocols are recommended for post-operative care following pancreaticoduodenectomy? Answer: protocols include avoidance of hyperglycemia, maintaining near-zero fluid balance, early drain removal, early oral intake, minimizing narcotic use, and encouraging mobilization. Question: when should the nasogastric tube be removed after surgery, and how should the diet be advanced? Answer: the nasogastric tube should be removed on post-operative day 1 or 2, with limited clear liquids introduced and the diet advanced over subsequent days as tolerated. Question: how should drains be managed post-operatively? Answer: early removal is recommended for low or intermediate risk patients based on drain amylase levels, with monitoring for pancreatic fistula or chyle leak after diet advancement. Post-operative complications. Question: what are the most common complications after pancreaticoduodenectomy? Answer: pancreatic fistula, 10 to 30%, and delayed gastric emptying, 10 to 15%, are common post-operative complications. Question: what is the most dreaded complication after pancreaticoduodenectomy, and why? Answer: post-pancreatectomy hemorrhage, 5%, is the most feared complication due to its high mortality rate. Question: how is the severity of post-operative complications scored? Answer: the severity of complications is defined by the International Study Group of Pancreatic Surgery. Pancreatic fistula. Question: what factors increase the risk of pancreatic fistula after surgery? Answer: risk factors include gland texture, main pancreatic duct diameter, and intraoperative blood loss. Question: how is pancreatic fistula detected post-operatively? Answer: detection is based on amylase-rich fluid from surgical drains or identification of peripancreatic fluid collections on computed tomography imaging. Question: what is the standard management for pancreatic fistula? Answer: management typically involves drainage, antibiotics, and somatostatin analogs, with surgical re-exploration rarely required. Delayed gastric emptying. Question: what characterizes delayed gastric emptying after pancreaticoduodenectomy? Answer: delayed gastric emptying is a troublesome complication with complex pathophysiology, which may be influenced by surgical technique. Question: how does surgical technique affect the incidence of delayed gastric emptying? Answer: anticolic gastrojejunostomy may be associated with lower rates compared to retrocolic gastrojejunostomy, and an acute angle between the stomach and efferent jejunal limb may increase risk. Question: what are the management strategies for delayed gastric emptying? Answer: treatment includes nasogastric tube decompression, prokinetic agents, and addressing underlying causes such as pancreatic leaks. In rare cases, percutaneous gastrostomy tube placement may be necessary. Post-pancreatectomy hemorrhage. Question: what are the types of post-pancreatectomy hemorrhage, and how do they differ? Answer: early hemorrhage occurs within 24 hours due to surgical hemostasis issues and often requires reoperation, while late hemorrhage, 7 to 14 days post-operatively, is usually due to pseudoaneurysm bleeding or gastrojejunostomy ulceration. Question: how is late post-pancreatectomy hemorrhage typically presented and managed? Answer: Late hemorrhage often presents as an acute gastrointestinal bleed requiring prompt recognition, resuscitation, and interventional radiology. Question: what are the treatment and outcomes for late post-pancreatectomy hemorrhage? Answer: treatment involves endovascular embolization or stenting to control bleeding, but the condition has a high mortality rate and may lead to complications such as abscess formation and hepatic insufficiency. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.